Imagine an overgrown finger so massive that it just completely dwarfs the rest of a child's hand.
Yeah, it's a striking presentation.
Right, and your immediate instinct as a surgeon is to to reduce that burden. But if you cut into it, the tissue simply will not heal.
It won't. It's literally starving for blood.
Exactly. So today, we are mastering the biomechanical paradoxes of pediatric upper limb anomalies. If you are a resident gearing up for the FRCS plastic surgery exams, you are in the exact right place. We're stripping away all the fluff today.
Absolutely. Zero fluff. This is a high-yield clinical review.
We're focusing strictly on the anatomical pathology, the classifications, and, the precise surgical interventions you need to know to pass your boards.
We are looking at the why and the how behind the anatomical structures that really dictate your surgical decision-making.
But before we jump into the pathology, hit that follow button right now on whatever app you are using to listen to this. That ensures you don't miss any of our future high-yield revision sessions.
Yeah, make sure you follow.
And if you find this clinical review helpful, take a quick second to rate the show. Also, if you really want to take your studying to the absolute highest level, you need to get a premium subscription.
Highly recommend it.
That premium access is literally the only way you can listen to our exclusive Journal Club and Clinical Cases episodes. And those are, frankly, absolutely essential for exam prep.
You really can't pass without them.
Right. So we have a highly focused roadmap today. We are covering 4 major pathologies. We've got macrodactyly, thumb hypoplasia, brachydactyly, and Madeleine's deformity. Let's get straight into it. We are beginning with the most striking visible anomaly on the wards, which is extreme overgrowth. Okay, let's unpack this. How do we differentiate true macrodactyly from a vascular lesion for the boards?
Well, it is a critical distinction to make. For exam purposes, true macrodactyly is strictly defined by the massive enlargement of both the soft tissue and the skeleton of a finger.
Both. That's the key, right?
Exactly, both. It is a condition noted either at birth or within those first few years of life. And crucially, its etiology remains totally unknown.
Oh, right.
Yeah, this is the dividing line from conditions where overgrowth is driven by a very specific, identifiable lesion.
Right. So if we are looking at a hemangioma or an arteriovenous malformation or even, multiple enchondromatosis like Ollier's disease.
Yeah, exactly.
That is explicitly not true macrodactyly. Those have clear underlying focal drivers. True macrodactyly is it's its own distinct anatomical beast.
Precisely. And the anatomy tells a highly specific organized story here. It is usually unilateral. The index finger is the most commonly affected digit, though, multiple digits can certainly be involved.
And it can affect the toes, too, right?
It can definitely affect the toes.
And there is a geographical mapping to this, isn't there? Like, it's not just a uniform, random ballooning of the digit.
No, not at all. It is highly structured. The enlargement maps directly to the cutaneous distribution of specific nerves. In the literature, this relationship is explicitly described as nerve territory-oriented macrodactyly.
Nerve territory-oriented. Got it.
Right. The overgrowth respects the anatomical boundaries of the specific nerve territory it falls under, which is usually the median nerve distribution in the hand.
Which brings us to the examiner's favorite arena, which is classification systems. Let's break down Flatt's classification of macrodactyly. First, we need to talk about the behavioral split, right? Static versus progressive.
That is the fundamental behavioral split you must establish before anything else. In static macrodactyly, the enlarged finger grows in proportion to the rest of the hand.
So it starts big, but...
It starts big, but its growth rate matches the child's overall skeletal maturation.
Right, okay.
Progressive macrodactyly, however, is much more aggressive. It actively outpaces the normal tissues, growing just entirely out of proportion to the rest of the hand. And this often causes severe angular deviation because the growth is so asymmetrical.
Wow, okay. So beyond that behavioral split, Flatt classifies macrodactyly into 4 specific pathological types. Let's look at the actual mechanics of each one. Type I is lipofibromatosis. But what is physically happening at the tissue level to cause the enlargement here?
Well, pathologically, you have epineural and perineural fibrosis. But the true driver of the massive volume is heavy, fatty infiltration of the nerve itself.
The nerve is filled with fat.
Yes. The nerve expands dramatically because it's being engorged with adipose tissue. This lepofibromatous mass then drives the surrounding skeletal and soft tissue overgrowth.
That is wild. Then type 2 is neurofibromatosis. I assume the nerve enlargement here is a direct physical manifestation of a plexiform neurofibroma?
Spot on. Type 2 occurs specifically in conjunction with systemic plexiform neurofibromatosis. The nerve is enlarged by the neurofibroma, which then cascades into that digital gigantism.
Okay, wait. So if types I and 2 are fundamentally driven by nerve issues, does that mean type 3 follows the exact same pattern?
Well,
Or are we dealing with a different anatomical driver here? Because type 3 is digital hyperostosis.
this is a classic board trick, so pay attention. Type 3 breaks the pattern entirely. There's absolutely no nerve enlargement in type 3.
None at all.
None. It involves osteochondral periarticular nodules. It is a strictly skeletal and articular overgrowth phenomenon. If you mention nerve territory or nerve stripping when discussing type 3, you will fail the question.
That is extremely good to know. And finally, type 4 is hemihypertrophy, which is essentially Proteus syndrome, right?
Exactly.
This is a massive systemic overgrowth condition that just happens to manifest in the digits. Now, I want to circle back to that clinical paradox I mentioned at the top of the session. You have this massive digit, an absolute excess of bone and soft tissue. But if you intervene surgically, you face disastrously delayed healing. Why does a finger with so much extra tissue struggle to close a simple wound?
What's fascinating here is the underlying vascular paradox. Despite the massive volume of overgrown soft tissue, the bone, and the engorged nerves, there is a severe relative vascular insufficiency.
Wait, so the blood vessels don't grow with the finger?
They do not. The digital blood vessels themselves do not scale up. They are rarely enlarged.
So you have the huge metabolic demand of an oversized digit, but it's being fed by the exact same caliber of vessels you'd find in a normal, tiny pediatric finger.
Exactly. So when you operate, you are mechanically operating on ischemic tissue. Because of this biomechanical reality, your standard surgical options are highly inadequate.
So what can you even do?
Well, you might attempt a soft tissue reduction, which can include digital nerve stripping to address that nerve territory-oriented growth. Or you might try closing wedge osteotomies to correct the angular deviation.
Right, or an epiphysiodesis to surgically fuse the growth plate.
Exactly, to halt the skeletal elongation.
Yeah.
Or ultimately, an amputation. But the poor vascularity severely compromises the healing of every single one of these interventions.
Okay, so we've seen what happens when tissue outpaces its own blood supply. But what happens when the anatomical foundation itself is completely missing? That brings us from a surplus of tissue to a critical deficit, thumb hypoplasia.
And this is huge. The thumb provides approximately 50% of total hand function. Losing it is a devastating mechanical blow to pinch and grasp kinematics.
Absolutely.
Furthermore, for the boards, remember that thumb hypoplasia does not exist in a vacuum. It is part of the broader spectrum of radial longitudinal deficiency.
Right, and because it sits on that specific spectrum, there is a systemic screening protocol that is an absolute must. If you have a child presenting with thumb hypoplasia, what is the mandatory screening?
You must screen these children for Fanconi's anemia. That is a non-negotiable step in your clinical workup.
Fanconi's anemia.
Yes. The association with severe genetic syndromes makes this a fatal oversight if you miss it on your boards.
Got it. Now here's where it gets really interesting, the surgical dividing line. To understand exactly when and how we operate, we have to walk through the modified Blau's classification. This divides thumb hypoplasia into 5 groups based on the structural deficits. Let's hit type I.
Type I is the mildest form. This is minor generalized hypoplasia. All the anatomical structures are present, they're just slightly smaller.
So function is generally fully preserved, and importantly, type I does not require any surgical intervention. But type 2 is where the structural deficits really begin to stack up, right?
They do. In type 2, you have 3 distinct biomechanical problems. First, the thenar muscles are hypoplastic, meaning active opposition is incredibly weak.
Okay, weak composition.
Second, because of that muscle imbalance, you develop a secondary adduction contracture of the first web space. The thumb is basically pulled tight against the index finger.
Right.
And third, there is primary insufficiency of the ulnar collateral ligament, the UCL, at the metacarpophalangeal joint.
So it's highly unstable. Moving to type 3, it gets significantly worse because it includes all the features of type 2, but it adds abnormal extrinsic tendons into the mix. Now, within type 3, there is a critical subclassification by Manska.
Yes.
This isn't just a classification. This is the ultimate surgical go or no-go gauge. Explain the biomechanics here.
Manska divided type 3 based purely on the skeletal stability of the carpometacarpal joint, the CMCJ. Type I3 has a stable CMCJ. It has a physical foundation you can build upon.
Okay, so IHE is stable.
Right. TAC-53 has an unstable CMCJ. The saddle joint base is fundamentally inadequate. It just cannot mechanically support the cantilever loads of a functional thumb pinch.
Wow. Then we have type 4, the classic pausflottend, or floating thumb. This is just a small thumb attached to the hand by a mere soft tissue bridge with zero functional skeletal continuity. And finally, type V, which is the total absence of the thumb.
Exactly. And let's establish that surgical pivot point right now. If you do not have a stable CMCJ foundation,
Which is types IAP, 4, and V.
correct. For those, reconstruction is completely futile. You cannot engineer stability out of thin air. For these types, they all share the exact same surgical fate. You must perform an ablation of whatever thumb elements remain and execute a pellicization of the index finger.
Right, so you take the index finger, you shorten it, rotate it, and reposition it to act as the new thumb.
Exactly. Pellicization is the gold standard to restore opposition and pinch in a foundationless hand. And it is ideally performed at 1 to 2 years of age, precisely when the child's cortical functional pinch and grasp patterns are developing.
But let's focus on the thumbs we can save, types 2 and I3A. This requires a highly specific, complex 4-step reconstruction. I want to drill down into the mechanics of this sequence because examiners will push you on why you are doing each step. Step 1 is the first web space release. You can't just make a simple linear incision here to release the contracture, can you?
No, a simple incision will just scar and contract again, completely defeating the purpose. You need to fundamentally deepen and widen that space, typically recruiting tissue with a 4-flap Z-plasty.
A 4-flap Z-plasty.
Right. Mechanically, you are trying to break up the linear scar vector and borrow skin laxity from the dorsum of the hand to recreate the web concavity.
And if the skin release isn't enough, you have to surgically release the first dorsal interosseous muscle from its origin on the second metacarpal. You literally have to mechanically liberate the thumb metacarpal from the index metacarpal.
That gets us our space. Exactly.
Okay, so step 2 is UCL reconstruction. We have a floppy MCPJ that will buckle under pinch pressure.
Well, the UCL deficiency might be primary, meaning the ligament just didn't form. But you must aggressively hunt for a secondary cause during your exploration, the pollex abductus.
Oh, this is a massive clinical trap. The pollex abductus is a pathological, anomalous anatomical connection between the FPL and the EPL, right? Flexor to extensor.
It is a biomechanical nightmare. It is like trying to drive a car with the parking brake fully engaged. When the flexor fires to bend the thumb, it simultaneously pulls on the extensor. The forces just cancel out and the joint buckles or deviates. You must surgically sever this abnormal connection before you can even think about stabilizing the joint.
Wow. Okay, so once that anomalous connection is released, you stabilize the MCP joint. You have options here. You can fuse it with the chondrodesis. You can use a free tendon graft to augment whatever vestigial UCL tissue is there. Or you can get clever and incorporate the UCL reconstruction directly into step 3, which is the opponent's plasty.
Right, because to augment the deficient thenar muscles, you need a robust motor tendon transfer. The debate is usually between the Huber transfer, taking the ADM and rerouting it to the APB insertion, and using the ring finger FDS.
I know a lot of surgeons heavily favor the ring FDS. Why is that mechanically superior in many of these cases?
The ring FDS gives you excellent excursion and power, but crucially, it gives you length. That extra length allows you to route the tendon slip across the MCP joint in a specific way that reconstructs the deficient UCL at the exact same time you are restoring opposition. 2 birds, 1 stone.
That is brilliant. Finally, step 4, extrinsic tendon reconstruction. Because in type TI, the extrinsics are usually compromised.
Often, you will need to transfer the EIP to the EPO to restore robust, independent extension of the thumb. And if the FPL is deficient, you aren't just reconstructing the tendon transfer, you must meticulously reconstruct the flexor pulley system.
Without a competent pulley, the flexor tendon will just bowstring across the joint, destroying your mechanical advantage.
Exactly.
Okay, so we've covered extreme overgrowth with macrodactyly and severe structural hypoplasia with the thumb. Let's shift our focus to situations where the volume of tissue is relatively normal, but the anatomical structure is fundamentally anomalous. Let's talk about brachydactyly, or simply short fingers.
Right.
It can occur in isolation or as part of a complex hand anomaly. It is often anatomically associated with syndactyly, clinodactyly, and symphalandism. So what does this all mean for our surgical algorithm?
This raises an important question, and it is a classic board trap. When you see an anomaly like severely short fingers, your surgeon's instinct is to mechanically correct it. But with brachydactyly, surgery is seldom required.
Because the biomechanics actually work.
Exactly. The fingers are short, yes, but the joints hinge correctly, the tendons glide perfectly, and the functional grasp is often highly effective. If you intervene surgically, say, with multiple osteotomies, in an attempt to merely improve the cosmetic length, you induce massive scarring.
Oh, wow.
Yeah, you trade a short, highly functional finger for a longer, useless, stiff finger. That is a catastrophic trade.
The only specific intervention really highlighted for boards in this context is for brachymetacarpia, right? An isolated short metacarpal that disrupts the normal cascade of the knuckles.
Yes. Here, you might use distraction osteogenesis to slowly lengthen the bone over time, but again, the threshold for surgery is incredibly high.
Got it.
If we connect this to the bigger picture, the absolute paramount theme in pediatric hand surgery is function over form.
Which perfectly transitions us to our final anomaly. Here, the growth disturbance doesn't originate in the digits, but proximally right at the wrist. Madelung's deformity. What is the precise biomechanical driver of a Madelung's deformity?
Madelung's is defined by excessive radial and palmar angulation of the distal radius. This happens because there is a highly localized growth arrest. The palmar and ulnar portion of the distal radial physis essentially stops growing properly, but the dorsal and radial portions continue to grow.
So the growing bone is literally forced to bow around that tethered, arrested corner.
Exactly.
And there is a highly specific pathological ligament associated with this tethering that you must know, Vickers ligament.
Yes. Vickers ligament is a rigid, abnormal palmar ligament. It creates a physical tether spanning from the lunate directly to the palmar aspect of the radius. It acts like an anchor chain, severely restricting normal growth and pulling the carpus into that distorted palmar tilt.
So how does this present clinically? I mean, it doesn't typically show up at birth like macrodactyly, does it?
No, the deformity becomes violently apparent in early adolescence during the pubertal growth spurt. As that asymmetrical growth rapidly compounds, it is usually bilateral. Because of the palmar and radial bowing of the radius, the distal ulna is basically left behind, becoming highly prominent and displaced dorsally.
And mechanically, because the carpus is sliding down that steep palmar slope of the radius, ulnar deviation of the wrist becomes severely limited. The forearm itself is usually quite short. But examiners will definitely test your systemic knowledge here. Madelung's is frequently part of Léry-Weill dyschondrosiosis.
Yes, a genetic condition resulting from a SHOX gene mutation that causes short stature. Because of this specific association, Madelung's is sometimes formally classified as a generalized skeletal abnormality rather than just an isolated wrist pathology.
Now, what about surgical management? As we established with brachydactyly, no treatment is required for painless deformities with preserved function. But for painful, severe deformities where altered joint kinematics are causing severe ulnocarpal impaction, what are the surgical options?
You have 5 distinct surgical pathways you need to be able to list for the boards. Number 1 is resection of Vickers ligament combined with a dome osteotomy of the radius. Mechanically, you cut the tether, and the dome cut allows you to rotate and anatomically reorient the joint surface into a neutral plane.
Right. And number 2 is a closing wedge osteotomy of the radius combined with ulnar shortening to level out the joint surfaces. Number 3 is an opening wedge osteotomy of the radius.
Number 4 is an osteotomy of the radius combined with a distal ulnar resection, effectively amputating the prominent, painful ulnar head.
And number 5, which is highly tested and biomechanically brilliant, is an osteotomy of the radius paired with a Sauvé-Capongé procedure.
The Sauvé-Capongé procedure is a masterclass in salvage mechanics. Think of a severely distorted distal radio-ulnar joint, the DRUJ, like a door with a completely rusted hinge. Every time you try to turn the forearm, that rusted hinge grinds and causes severe pain. Instead of trying to force the rusted hinge to move, the Sauvé-Capongé procedure fuses it completely shut. You permanently stabilize the DRUJ.
But wait, if you fuse the DRUJ, you lose all pronation and supination. How do you get forearm rotation back?
By cutting a clean slice out of the door itself, you surgically resect a small segment of the ulna shaft just proximal to that new fusion. By creating that purposeful pseudoarthrosis in the ulna, the proximal ulna can now rotate freely. You allow the forearm to bypass the fused joint entirely, acting as a brand new swivel point. It is a highly effective procedure for these distorted mechanics.
Incredible. Which brings us to the end of our anatomical review.
Yeah. As you continue your board prep, I want to leave you with a higher level synthesis regarding the biomechanical battle of pediatric growth anomalies. Whether it is the delayed healing of a massive, overgrown macrodactyly digit due to surprisingly poor vessels, or the severe risk of creating a stiff, non-functional hand by operating on a short but perfectly mobile brachydactyly digit. The hardest surgical decision you will make is often choosing not to operate.
That's very true. Recognizing when anatomy looks completely abnormal on an X-ray but function is fundamentally preserved is the true mark of a master surgeon. Before you get back to your studying, I want you to drop a comment or a question in the platform's interaction section right now. Tell us, which of these classification systems, flats for overgrowth or blouses for undergrowth, do you find the hardest to memorize and why? Drop that in the comments and then get back to the books. We'll see you on the next deep dive.